Thank you, Lucy. Hello. I think there are some of my friends out there listening as well, and I'm really kind of excited to talk about something that's near and dear to my heart, which is breastfeeding and medications, as that is a common question given to me from not only the healthcare provider team, but mothers and in particular physicians. Oh, I don't have control. Okay. I have no financial relationships to disclose. Just a brief outline of what we're going to be covering. Just a quick reminder on benefits of breastfeeding. We'll focus on one area, in particular the gestational diabetic baby, what contraindications are to breastfeeding, what about medications? So how do medications pass into breast milk? What factors increase the likelihood of passage into milk? How do we get levels of medications in moms, milk, and babies? And then specific calculations that help us assess what medications are safe and giving some more objective data on how we can rate medications and know that we are safely administering them. What resources are there? And we'll talk about textbooks, online issues, and then in particular my favorite would be phone applications. And then we'll review some of the common medications in the postpartum period, in particular when we're establishing lactation. So this is my favorite slide, and every time anybody lets me talk, I like to throw it up because I think it is very compelling. It speaks to the great benefits of breastfeeding for the infant, particularly decreased infection, decreased inflammatory disease, decreased sudden infant death, and then diabetes as well. And I'm going to focus, every time I try to focus on one area so as not to overwhelm. So I'm going to skip lactoferrin, human milk oligosaccharides, all that good stuff, and really focus on obesity and diabetes. So when you look at the breastfed infant, they do have decrease in obesity and diabetes. Insulin is a normal component of breast milk, and it promotes gut maturation and reduces intestinal permeability to macromolecules. It may also induce tolerance to insulin, protecting from type 1 diabetes. When you look at a baby who has a mother who has either pregestational or gestational diabetes, there is decreased diabetes in the infant when they are breastfed. And our new favorite topic, which is that colostrum can stabilize infant blood glucose, because it enhances gluconeogenesis, and maybe something we should push more in our nursery environment and getting that colostrum to the babies who are concerned about having low glucose during transition. When we look at mom, this is kind of a review for probably everyone in the audience, but we have lactational amenorrhea that increases the interval between births, decreased postpartum bleeding, as well as more rapid uterine involution due to that oxytocin effect. Earlier return to pre-pregnancy weight, although I did not personally experience that, but apparently data says so. Decreased risk of breast cancer and ovarian cancer, some decrease in bone issues, as well as increased self-confidence in mothering abilities. And especially in my environment in the neonatal intensive care unit, there's an increase in contribution to caring for their preterm infant. We look at moms who are gestational diabetics, and if they breastfeed, they're less likely to develop type 2 diabetes as they age. And then we have some decreased rheumatoid arthritis and cardiovascular disease, including hypertension, hyperlipidemia, per the Women's Health Initiative. When we look at moms again, you see decreased risk of obesity by 1% for each 6 months of nursing. And a lot of my colleagues will say, but that's 1%, but 1% is any percent. And when we look at a non-diabetic mother, their decrease in incidence of diabetes goes down by 14 to 15%. When we look at a diabetic mother, they actually have decreased insulin need in the peripartum period because they're transferring some of their sugars into the breast milk. And they will have a 36% lower basal insulin requirement, and that's also due to glucose use for milk production. And then again, it may be helping our diabetic mothers with weight loss if they are type 2 diabetics and insulin resistant, and decreasing that obesity and may help with mitigating their diabetes. Community, decreased cost across the board. So it's cost in billions due to annual health care, WIC costs go down, cost to the GNP due to parental employee absenteeism due to infant being ill and parents needing to stay home, decreased environmental burden due to formula waste, and decreased energy demands due to the need to make formula and then transport that formula to be purchased. When we look specifically at breastfeeding, what are the contraindications? And I always like to tell everybody there are very few contraindications to breastfeeding. In general, breastfeeding is the right path to go. There are a few situations. In our environment, HIV is a contraindication to breastfeeding. In certain environments, HIV is actually not a contraindication, such as a third world country where the water source is not safe. And as long as mom is committed to exclusive breastfeeding, it is felt to be the better option. HSV lesions on the breast is another contraindication. A mom who is symptomatic with a positive PPD and a positive chest x-ray where they are presumed to have active clinical tuberculosis, breastfeeding would not be supported, as well as moms who have active breast abscesses. And absolute contraindication would be galactosemia because the carbohydrate in breast milk is lactose. Certain medications and drugs, so illicit substance abuse inherently is a contraindication, especially medications like cocaine, methamphetamine, and then we look at other drugs, cyclosporin, lithium, who is known to concentrate within breast milk, methotrexate, phencyclidine, radioactive agents. Other contraindication would be flu until afebrile, and then varicella if developed 5 days or less before delivery or within 48 hours after delivery, although one can use express milk in this setting. This 5 days and 48 hours, I always get confused and regularly reference the Red Book and would encourage everyone to do so. What are not contraindications to breastfeeding, which I imagine a lot of you know this, is hepatitis B positive mothers and hepatitis C, moms who have a fever, moms who have CMV positivity, except for there is debate within the preterm population, as we do still in some areas believe that CMV in the preterm population should be avoided and mothers do not give their milk. We in the United States do not pay attention to CMV status of the mother. In Europe, they do. Maternal smoking, which I would argue you're neutralizing or at least trying to balance out the effect of risk for SIDS with maternal smoking and then the benefit from breastfeeding. And my general recommendation is, if in doubt, start pumping and check with the lactation team or a physician. And this is going to apply to medications as we go through as well. But the error should not be on you can't breastfeed. The error should be on I'm not sure, go ahead and keep pumping. If I'm not sure about the breast milk, do what we need to for baby, and then let's go ahead and figure it out so we can keep going and maintain that milk supply. So keep pumping until we give you a definitive one way or the other. So what about those medications? How do medications pass into breast milk? We're going to cover that. What factors increase the likelihood of passage into breast milk, as well as looking at levels and then the calculations, specifically the milk to plasma ratio and the relative infant dose. We'll go over what resources there are, and then again, look at those medications that we commonly encounter in the peripartum period. So how do medicines pass into milk? Diffusion, or movement of a drug from high concentration to a low concentration, is generally the method. When we look at simple diffusion, these are small water-soluble non-electrolytes that can pass through the spaces between the cells and the mammary epithelium. And this gets rapid equilibration between milk and maternal plasma. So you don't tend to see significant high to low gradients because it can pass so easily that they do equilibrate quickly. Passive diffusion is for unbound, non-ionized forms. It's driven by that concentration gradient, but the medication may require more time or have a harder time crossing the mammary epithelium. So you need a higher maternal plasma to milk concentration so that we're going down the gradient. Active transport, when you actively have energy utilized to transport up the gradient, meaning you're going from low to high concentration. There are a few small molecules such as acyclovir, cimetidine, and nitrofurantoin who do cross through active transport. There are some active transport that isn't specifically low to high concentration, but there is a mechanism that transports the medication across. So what factors do increase the likelihood of passage into breast milk? A low molecular weight, so a small molecule. Low protein binding, meaning that it's not bulked up by having large proteins tacked onto it. A weak base, and that means that we have weak alkalinity or weak negative ion, which allows it to follow the pH gradient between mother's pH and breast milk's pH. And then high lipid solubility, and that's because it's easy to go through lipid-laden membranes when you have a lipid-soluble medication. So looking at specific levels, maternal plasma level, which is critical in assessing whether medication is actually in a risky or potential risk to the infant. How high is the maternal level? And then looking at the transfer of milk down, or the medication into the milk and then absorbed by the baby. So the first step is how high does the medication get in the mom? And this can vary by dose administered, the half-life of the medication, the volume of distribution, oral bioavailability, which is important for mom as well as for baby, and if it's protein bound. Like we talked about, protein binding will decrease the likelihood of it. Even if it's in the plasma high, if it's protein bound, it's less likely to transfer. Another thing to remember that as maternal levels fall below milk concentration, the drug can go backwards out of the milk and into the mother's plasma. And that's that common recommendation when we say if you're going to have a glass of wine, spend as much time between breastfeeding, drink the glass of wine early, and so that the time that you're going to breastfeed will be further out so that that medication or the alcohol has the chance to go back into mom's serum as she metabolizes it. So when we move on to the milk to plasma ratio, this is looking at how does the milk going from mom's plasma level and then to the milk level, is it a direct 1-to-1 or is it less than that? And are we losing in that we're not actually having a direct equilibration? And that lets you know how well it crosses into the milk. And it is a ratio of the concentration of the drug in the milk to that in the plasma. So we're measuring plasma concentration of drug and milk concentration of drug. And what is felt to be high is greater than 1-to-5, which would mean that you're actually concentrating the medication in the milk. And that it's sequestering the milk in high levels and would be more concerning for it being worrisome for baby to have side effects. It is very difficult to accurately measure because you have to be very time dependent in that you got to get the milk, sample the milk and mom's plasma at the same time and make sure that you know that was the time that the baby was feeding. And is mom taking the medication every 3 hours? So it's very hard to say specifically, and it's hard to generalize across. In general, it's less than 1-to-1, meaning if the medication is staying more in the plasma and not transferring as much to the milk, that's a less than 1-to-1. So 0.5-to-1, things like that would be more reassuring, although not definitive, as it is a very difficult set of levels to measure. So this isn't generally used anymore, and we move into what is called the relative infant dose, which is now looking at what is the baby getting. So we look at how much is in the milk and then how much the baby is getting, and it gives us an idea. So how much are we giving into the baby? So this is daily infant dosage in breast milk, milligrams per infant weight in kilograms, divided by daily maternal dosage, or milligrams per maternal weight in kilograms times 100. And this gives us how much of the medication actually gets into the breast milk. And what we're looking for is a less than 10%, because that's considered acceptable in breastfeeding. If greater than 25%, it's considered unacceptable. 90% of drugs fall below the 10th percentile or 10% level. There's only about 3% of drugs that will go over that 25% considered unacceptable. And that's really important because the response that I generally hear from anybody who asks me about medications and breastfeeding is, my doctor started this medicine, he said it probably wasn't okay and I should just stop breastfeeding or pump and dump because it's not going to be safe. We really need to change everybody's perception, not just physicians, but in particular physicians, because I can blame my own people, but really that the answer should be, I'm pretty sure it's going to be safe, but let me look it up. And if I don't know how to look it up, let me call someone who can, but keep pumping and maintain that milk supply, even if we don't know 100% right now, but most likely we're safe. There are a few exceptions to the relative infant dose. Those drugs that have very long half-lives or an infant who has a genetic susceptibility, somebody like a G6PD, and we'll go over one of those medications as we go through specific medications. So just to summarize what I've gone through so far, drugs that transfer into human milk are highly lipid soluble. They have high concentrations in maternal plasma. They're low in molecular weight, less than 500. They're low in protein binding. Their milk to plasma ratio is less than 1-to-1. It's felt to be usually safe. The relative infant dose is less than 10% of the maternal dose is felt to be safe. So how do we as providers know which medication is okay? So when I'm asked off the cuff and I don't have my phone, which tells me everything, two questions I can ask myself very quickly is, can it be given to infants? If I can give it to one of the babies in my NICU, I'm pretty sure it's going to be safe for mom to get. So an ampicillin, things like that I know we use quite liberally in the NICU, I can feel comfortable. Or even to infants in a pediatric practice, we can feel pretty comfortable that baby will tolerate it. Is it orally bioavailable? A drug that isn't orally absorbed is absolutely going to be a low-risk event because the baby's got to be able to absorb it from the breast milk. When we look at resources that are available for checking medications, and it's my training, we always ran to the Hale book, which was usually 3 editions behind because you can never seem to keep the good book on the shelf. But you had to go take the time and get the book, and there's all these wonderful textbooks out there, but having something readily available on your phone or popping onto the internet if you've got a workstation on wheels is helpful as well. So LactMed, which is the NIH site, the TalksNet, and I'll have the website down below on the next couple of slides. It's a great resource, and I'll show you some of it on their phone app, that what they tell you. But it tends to be very narrative in what tells what the risks they've seen, but they don't actually give you a yes or no. There's no stamp of approval. So I find it a little bit harder for families when I say, really, this is what it says. Then they look at me and go, okay, but I'm not in medical field. What does that mean to me? So it's not quite of a thumbs up moment, and which is a little bit less easy to translate to parents, as well as to some physicians who really want to be reassured that administering a medication is safe. The AAP Committee on Drugs also has a recommendation for which medications are safe. Hale's Medication in Mother's Milk textbook is wonderful, or text. The Infant Risk website and MommyMeds app. You can go to infantrisk.com, or there is an app, and I'll go through that one with you guys as well. That's my preferred go-to because it's quite easy to search. It tends to be very well updated and gives me that thumbs up or 2 thumbs up to make me feel very comfortable, and to show families, I actually show them the app on the phone and say, look, it's got a big green sign. It's green means go. So that tends to make people more comfortable with it. Lawrence and Lawrence, the Breastfeeding, A Guide to the Medical Profession, as well as Briggs, Freeman, and Yassie's Drugs in Pregnancy and Lactation are great resources. The Lactation Center, Study Center Drug Data Bank out of Rochester, New York, is also a great place to look, because that's really the center of phenomenal work in breast milk right now. So I am going to reference my favorite rating scale, which is the Hale scale, because I think it's very easy to wrap your head around and makes everybody, you can communicate very quickly when somebody says, can I use that milk? And I say, yeah, it's an L1, go for it. They feel very comfortable. So I'm just going to run you guys through the Hale rating scale. L1 is the safest and is deemed to be compatible. There may or may not be extensive data suggesting there is little risk to a breastfeeding infant, but it's generally not bioavailable to the infant. L2 is safer or probably compatible. It's limited to extensive data that suggests there are only limited risks to a breastfeeding infant, but the evidence for risk is remote. L3 is moderately safe or probably compatible, so no or limited data suggests this drug may be compatible in breastfeeding mothers. Controlled studies only minimal non-threatening adverse effects. Now in L3, they say use only if risk is justified. And we'll talk a little bit about risk-benefit as we go through some of the specific medications. L4 means that it's possibly hazardous. There's no data to significant data that suggests there may be a possible risk to a breastfeeding infant, but the benefits from use in breastfeeding women may be acceptable despite the risk. And we'll talk about that as we go forward too. Evidence of risk to the breastfeeding infant is really what is deemed on the L4. When we look at L5, this is our hazardous or contraindicated medications. And this is significant risk or damage to the infant, and that should be avoided if at all possible. And generally, like I said, it's 90% of our medications are going to fall into that L1 to L3, where we feel very comfortable utilizing that, or we can find an alternative that is safer. So this is an app that I like to recommend to everybody, especially those who aren't as comfortable with breastfeeding. It goes over a lot of basics, but it is out of the Hale group in Texas, and it does go into some detail with breastfeeding and medications. This is the LactMed site, and this is not the site. The app is the images you're seeing. The website there is actually if you want to get onto a regular computer. But the application is quite nice, and it's on your iPhone, so it's with you if you tend to be like me and carry your iPhone and feel lost without it. It's searchable. It gives you a nice narrative on it and what is known, but it doesn't give you that thumbs up. It kind of leaves it for your interpretation to say whether you think it's safe or not. This is the Infant Risk Center. Infantrisk.com is the actual computer site if you're going in through the web, but the images are also from the app. This app I find very useful, and it's the one I go to whenever I get a text from all of my colleagues when they want to know if a medication is safe or not. And the example I have up there is acetaminophen, and it's a CHOC plus in the pregnancy time and CHOC plus during breastfeeding after delivery. And I like this one because you can even click on the blue or the green, and look at what it's saying for 0 to 6 months. But what's nice about this one is it gives you all the possible names it can live under, what your average dose is. It gives you the lactation risk of L1, and it also gives you that relative infant dose, and then goes through a narrative of what you would see and if there needs to be any screening or guidance. So this is my favorite place because it really narrows it down and simplifies it for me so I can give somebody an answer very quickly, knowing that it's a safe and trusted resource, and it is quite reliable and user-friendly. So now we'll take a look more at medications specifically. So contraindicated medications in general are your amphetamines, chemotherapeutics, ergotamines, and statins. And then I always like to say drugs that should be used in caution are those that are going to inhibit milk production. So your ergot alkaloids, decongestants, betamethasone, high-dose vitamin B6, and diuretics. Now, we know diuretics often have to be used in some women who have hypertension postnatally, things like that. So it's judicious use of these drugs if we have to, and being mindful of the fact that we may be inhibiting milk production. So they're not really contraindicated, but they should be avoided. So now we're going to go through some of our specific medications, the common things that we're going to encounter, particularly for me in that early peripartum period, where we see need for pain control, sometimes antibiotics, blood pressure management, diabetes management, things like that. So we're going to go by class. So we're going to start with pain control. Percocet is one of the most commonly used that I see in pain control for moms. It is L3. There is limited data, but it's probably compatible. And just to clarify, everything that I'm telling you guys now is actually coming out of the app. This is the information that I could get directly off the app. And so with the touch of a finger while I'm running around seeing patients, I can give anybody this information very easily, and it's actually very user-friendly. So Percocet, the acetaminophen is L1, deemed to be minimal risk to the infant. The oxycodone is L3. It's secreted and may concentrate in the milk. And this is important to educate mothers on it, that they can see some sedation in the infant at higher doses. So really letting them know and reminding our obstetric colleagues not to have moms taking more than 40 milligrams per day of the oxycodone component of Percocet. Ibuprofen is my favorite drug, and I think it's probably the favorite drug of most lactation specialists as well, is that it's L1. It's super compatible. It's the ideal analgesic for breastfeeding moms. It's secreted minimally into the breast milk, and it's commonly given to infants. Now, generally, when you think of ibuprofen, general recommendation is at greater than 6 months, but we do utilize it even in the neonatal period, although with more caution. But it's well tolerated in general, except for maybe by the preterm infant. So this is a great drug in that you're not going to have a lot of transfer anyhow, and it will be tolerated by the baby. Moving on to antibiotics, which are commonly administered around the delivery time and even later on. Kind of good old classic antibiotics is what our obstetrical colleagues use because they are smart and they're picking drugs that are generally safe for babies. So macrobid or nitrofurantoin is an L2. There's limited data, but probably compatible. And it is minimally secreted in the breast milk, which would argue that we would have low doses in the milk. Now, there is caution. This is that genetic predisposition is infants with G6PD or less than 1 month old who have jaundice issues, and that's because of the risk of them having side effects in their bilirubin metabolism. Keflex, another classic antibiotic, L1, limited data but deemed compatible, and there's large experience in breastfeeding mothers. Amoxicillin, another good old-fashioned antibiotic, it's L1, limited data and compatible, large experience in the breastfeeding mother. It's used and well tolerated by neonates. This amoxicillin or ampicillin is our go-to antibiotic in the NICU and is tolerated by exclusively everyone, actually. We universally can use this medication. Bactrim is a little bit more concerning from the neonatal standpoint, but it's L3, limited data, probably compatible. It does secrete into the breast milk in small amounts. Caution is recommended in the preterm or jaundiced infant or if less than 22 days. It does affect bilirubin metabolism again in the newborn, so caution in the first 30 days of past delivery using that antibiotic. Moving on to diabetic medications, insulin is L1. It is limited data and compatible because it really does not cross and has poor bioavailability. So it's a well-tolerated and it is probably a lovely lactation-related glucose management, although I'd argue it's harder on the mom. Metformin is L1, limited data and compatible, and we see this used all the time, and it is safe to use in breastfeeding, has been used a lot in breastfed infants and mothers with breastfeeding infants. Transfer to milk is minimal, and plasma levels are undetected in the breastfed infant. So when you're looking at plasma level, who then goes to milk, that then is absorbed by baby, then what is baby's plasma level, and that is very low. Infants of mothers who took metformin during pregnancy and lactation had normal growth, motor, and social development. So that's even more reassuring that this is safe to utilize during the breastfeeding period. Other common diabetic medications, glyburide, which is an L2. There's limited data, but it's probably compatible. Again, low transfer to the milk, and then levels are below limit of detection in the milk. No changes in infant plasma glucose levels. Glipizide, another classic. Again, it's very similar to glyburide, so it's well tolerated. Prandin, which is a new antihyperglycemic, L4, no data and is possibly hazardous. So there's no data on transfer into human milk, but rodent data suggests transfer with hypoglycemic and skeletal changes. But the dosing regimen isn't terribly clear there, and the translation from rodent to human. So there's data that's worrisome in an animal model, and so one would argue that we should avoid it, and there are other quite reliable options. But the recommendation is if it must be used, then monitor the infant for hypoglycemia and breastfeed several hours after the dose to reduce exposure. So that may result in getting in the way and making breastfeeding a little bit more cumbersome. If you're taking a medication and you have to wait 4 to 6 hours, there may have to be a bottle feed in the middle, which is not ideal for, especially for establishing the milk supply. Further diabetic medications, Avandia or rosiglitazone is an L3. There's theoretical transfer, but thought to have a low relative infant dose and not felt to be clinically relevant. Januvia, and these are all new to me, is L3 and is probably compatible. Precose or acarbose is an L3 and probably compatible with low oral bioavailability, which is 2%. So if you look at maternal serum or plasma levels and then into the milk, and then even what actually gets into the milk is only 2% absorbed, you're looking at a very low amount of drug getting to the baby. And Invokana, which I looked up last year, not quite this time, but then it's been almost a year. They still have not updated this on the list, so I don't think they have enough data yet to talk about it. So this would be one to avoid when there are so many other reasonable options. Antidepressants. And I think this top statement is really the most important thing. Risk of untreated depression is far higher than risks of medication. And in general, a mother who is depressed and the resultant poor bonding, a non-stimulating environment, you're going to end up having a baby who's more significantly affected from that than any deemed perceived risk from being exposed to any of the antidepressants. That being said, there are preferred antidepressants because of their profile and that they do have a decreased risk to the baby. So Prozac, which is one of our classic SSRIs, is an L2. Preterm infants can develop toxicity after they have continued exposure in the breast milk. And if a baby is born to a mother who's been on this prenatally, they have steady state levels, and each time they breastfeed, the infant level may rise a little bit. There is a discontinuation syndrome or a withdrawal syndrome that it's sometimes difficult to tease out, but it's often just some irritability and excessive crying. And that can result where breastfeeding may be the right answer to ease that transition. Zoloft, which is one of our preferred antidepressants, is an L1 with extensive data. Milk levels are low, and there is felt to be no effect on the infant. It's poorly absorbed in the infant and does not affect platelet function. And like I said, this is one of the preferred antidepressants. Celexa is L2. It does have an unfortunate side effect that does come up of somnolence, colic, and restlessness in the infant. And these are older reports. Newer studies of babies that are exposed to Celexa through breast milk is less definitive on that. But when you have an option such as Lexapro, one would prefer to go to Lexapro instead, and that is deemed the preferred version of antidepressant, which is an L2, has limited experience in breastfeeding mothers, but the milk levels are low and infant plasma levels are low to undetectable. And then we look at Paxil, and this one is safe for babies. It's an L2 with low milk levels, and the relative infant dose is 2.8%, which is well below that 10%. The problem is there is some concern for use in pregnancy. So this wouldn't be a medication that would be a good idea to use long-term to start mom on during pregnancy if she's already got a long-standing history of depression, unless that's her drug medication prior to becoming pregnant. Moving into some other common complications of pregnancy, especially antihypertensives, we see them used for short periods of time, especially around the peripartum period. Methyl-dopa or Aldomet, which is an L2, and the levels that are transferred into the milk are minimal, and there are no adverse effects reported in infants. So this is the preferred antihypertensive. And the good news is our obstetrical colleagues tend to know this, because Aldomet is not a drug that I use a lot in my training, and only really got to know it because it is an obstetrical medication, and that our obstetrical colleagues are quite smart and are picking medications that are treating the issue but also safe for the babies. Same can be said for propranolol or Inderal. It's L2. It is the preferred beta blocker. There are low milk levels, but one does need to observe the infant for low heart rate, sedation, hypotension, and actually a hypoglycemia. There is concern with long-term exposure that you may have an increase in dose. Labetalol or Trandate, milk levels are extremely low. This is another one that we see our obstetrical colleagues prescribing a lot. Antidiuretics, and that top bullet there, all diuretics have the potential risk of decreasing milk supply. And so these drugs should be used with caution and only judiciously to treat the underlying issue. So Lasix, which is an L3, it is known for low oral bioavailability. I can speak to that from the neonatal practice, where when we move from IV Lasix to oral Lasix, many of my colleagues will double the dose because the oral bioavailability is so poor. So mom has to be taking a large dose for it to get into the breast milk and then be absorbed by the baby. So it is deemed to pose minimal risk to the infant. Hydrochlorothiazide is an L2. It's deemed a clinically insignificant amount is potentially ingested by the infant, and there is an undetectable infant serum concentration. Spironolactone is an L2. It's metabolized to canrenone, which is secreted into milk. The relative infant dose is only 2 to 4% of the maternal dose. So it's too low to really be clinically significant, and they're not seeing side effects. Cholesterol lowering. This is just generally not a medication that should be utilized during breastfeeding. And the argument is that atherosclerosis, and this is from the Infant Risk Center specifically, so atherosclerosis is a chronic indolent disease. It occurs over years. Discontinuation of these medications during pregnancy and lactation are unlikely to impact the outcome of the long-term disease. And what's really important is that cholesterol, and this is very, in the neonatal, we actually screen for cholesterol level because we know cholesterol is so important, especially for neurodevelopment. But cholesterol and cholesterol biosynthesis products are essential components for fetal and neonatal development. And using a cholesterol-lowering agent does not make sense in that setting. So generally, one shouldn't use anti-hypercholesterolemics during breastfeeding or pregnancy. Now, when we get into galactagogues, which are controversial at best, we utilize them in the NICU in the less than 32-week population because that's where the data is supportive. But I think galactagogues are great, but more importantly, it's doing what many of my colleagues in labor and delivery who have done a phenomenal job of getting moms pumping and hand expressing in the first hours after delivery. And so in my environment where I work, where lots of babies are separated from their mothers, we don't get to do skin to skin due to the clinical illness of the baby or mom. The L&D team is doing a phenomenal job of getting mom on a pump within an hour to 2 hours of delivery, making sure they're learning hand expression and doing it routinely in the first days to really help establish that milk supply so that the use of galactagogues isn't needed. But should one require galactagogues, you can look them up in these sites, including the Risk Center. And Reglan is an L2. You get out, it elevates plasma prolactin levels in lactating women. It can result in sedation and depression in moms, and it can cause tardive dyskinesia after 3 months of exposure. So it has risk more to mom than to baby. And whether there's benefit or not is sometimes debatable, especially if you're using in the over 32-week population. Domperidone, which is not FDA approved and is working toward orphan drug status, is an L1. There is a large experience in breastfeeding mothers, just not in the United States, or not openly in the United States. It is a peripheral dopamine antagonist, and it will increase serum prolactin and stimulate milk production. So if we're utilizing these for milk production, they're safe for the baby. There's some risk of irregular for mom with that black box warning, but overall, more importantly, is to avoid needing these by doing good hand expression and pumping early on, or getting the baby on the breast and following that golden hour. Herbal medications, I didn't want to spend too much time because I figured we'd run out. They are not FDA regulated, and I could spend a whole another hour and a half on just herbal galactic drugs. But then being FDA regulated and not really even being studied for what constituents are within the herbal, and then what is being transferred to maternal serum, and then to milk, and then to baby, that ideally needs to be studied so that we can have a relative infant dose and ideas of maternal plasma levels to get a handle on how that's going to affect baby. And I think, wow, I went fast. So I am a few minutes ahead, but I thank you. I think it's really important just to summarize the whole thing. Generally, medications are safe in breastfeeding, or there's a wonderful alternative that is known to be safe. It's a rare situation where we need to, and most of the time I'll walk into a room and say, we can do this. We can use your breast milk. Let's get going. And so really the most important thing is to say, I don't know, let me find out, but keep pumping for now and we'll figure it out. The answer really shouldn't be the old guard of let's pump and dump, or your milk isn't going to be safe, so just switch to formula. And how we get that message out is really going to the entire healthcare team, from bedside nurse to outpatient physician, inpatient physician, and really to get our lactation consultants out there sharing with people that in general medications are safe.
Well, thank you very much, Dr. Bixby, for your great insights on medications. If anybody has any questions, let me remind you to go ahead and write them into your question. Up at the very top, probably of your computer, is the control panel under questions, and go ahead and write in your questions. We'll wait a few minutes. Again, I thank you, Dr. Bixby, for that. Even that final point is very poignant. Of there's always something that we can do in regards to medications, and whether it's switching it to something different. I especially liked your point on depression and how severe that can be without medications. One of the questions that is here is fentanyl and morphine okay to use for pain control, for other things as well?
So you have me. Oh, okay. Yeah, fentanyl and morphine, we utilize them in babies. So the answer to the first off the cuff is absolutely. It is with caution, like the oxycodone, but allow me to look it up for you just so I can read it specifically. I can tell you in my practice, we use fentanyl in the neonate, but also fentanyl is becoming a more regular drug in mothers, morphine as well, especially around the delivery time. Timing is important for respiratory depression, of course. When we look at it in the breastfeeding baby, it's an L2, and the relative infant dose is 2.9 to 5%. So you're looking at a safe relative infant dose. And it's the same things as that oxycodone. So side effects are sedation, respiratory depression, bradycardia, some constipation that we see even in our mothers too. So, but it is a blue check plus for after delivery. Before delivery, it's a P3, excuse me.
Thank you. So what we want to say is basically everything crosses the breast milk. We just need to be careful as to how much and when. Is that a safe statement to make, to really kind of look at?
Well, I think it's
yes, everything that crosses the breast milk.
not everything can cross the breast milk. There are certain things that are poor, like insulin does not really cross because it just is not orally it may cross in the breast milk, but it's not orally bioavailable. So things can cross in the breast milk. Certain things do not cross well because of their size, or they have bulky protein binding that makes it very hard for it to cross between the two, across the epithelial layer. So it's more a matter of looking at the global, how much of it in mom, how much that's in mom's level, and what is mom's level. Does it get into the milk? And then even if it gets in the milk, is baby going to even absorb it? Because a orally bioavailable drug is not going to be absorbed by the baby. So it can get into the breast milk, and the baby's going to poop it out, and it will never get into the baby's system.
Thank you. Another question is regarding high viral load with hepatitis B or mothers who are on antivirals for that. Is breastfeeding contraindicated then?
So I would actually defer to my infectious disease colleagues based on viral load, but we have not, the transmission rates of hepatitis B, and I'd have to look at the red book and can get back to you, but it's not deemed to be a high likelihood of transfer there, especially because if mom's hepatitis B positive, we're of course going to be giving HBIG as well as Hep B vaccine at the time of delivery to minimize transmission and to boost the immune system at that point in time. But I can't speak to if there's a certain viral load. That has not been in my practice. It's generally let a mom with Hep B. I will tell you I haven't run into a lot of women with high viral loads, but usually if they're Hep B and H big, then we're fairly comfortable proceeding.
Thank you. Just to clarify, which antidepressant medication was the preferred medication?
It is, let me just go back, Zoloft and Lexapro. Zoloft, there's that one on that. I don't know, do you guys have the slides still or no?
It should be up on your screen.
Yeah, so Zoloft and Lexapro. But I would argue that Prozac is a nice safe drug as well, except for this discontinuation syndrome. And there may be greater comfort with Celexa as time goes by.
Okay, we'll wait a couple more minutes to see if anyone else has any further questions. All right, well, I think if no one has any further questions at this time, I want to thank everybody for attending, and thank you to Dr. Bixby for your insights on medications and breastfeeding. I know medications of any kind always make people feel very uncomfortable with how it affects the neonate, and we really appreciate the insights that you have on that. The handouts will be available after the webinar, and a PDF will be emailed to you. If you have any further questions or need assistance, please feel free to email myself, Lucy Van Otterloo, at the Community Perinatal Network, or Connie Von Kohler at the Perinatal Outreach Education Program. And let me remind you that you will also get a webinar, you will also receive an email with instructions on completing the online evaluation to receive your continuing education credit. Thank you to everyone who attended. Appreciate your involvement in this, and I look forward to the next webinar that we will be presenting. And everyone have a great afternoon. Thank you.